Welcome to Final BDS Made Easy. In this video, we are going to discuss the 5-marker question from Pediatric and Preventive Dentistry, that is the oral screen. The oral screen is a functional appliance used in pediatric and preventive dentistry to control abnormal muscle habits such as tongue thrusting and mouth breathing, and to correct developing malocclusions by utilizing the musculature effectively. It serves as a barrier to prevent adverse muscle forces and directs them into beneficial activities that help in aligning the dental arches. With the structure and function, the oral screen is typically made from modified acrylic. It can be constructed with an acrylic or wire loop barrier to prevent tongue thrusting. The combination of oral and vestibular screens controls muscle forces both inside and outside the dental arches. When constructed properly, the oral screen intercepts abnormal muscle forces, channels them into beneficial activities, and reduces the development of malocclusion. It can be used in conjunction with fixed orthodontic appliances to enhance treatment outcomes. Clinical applications. First is correction of malocclusion. If anterior tongue placement is due to an existing anterior open bite, correcting the malocclusion can lead to an adaptation of the tongue swallow pattern to the new tooth position. For example, for complex tongue thrust cases, active orthodontic treatment followed by myofunctional therapy is recommended during the retention phase. Next is surgical intervention. In cases involving retained infantile swallow, behavior or skeletal malformations, orthognathic surgical procedures may be necessary along with myofunctional therapy. Reduction of excessive lymphoid tissue can also lead to improved tongue position and function. Third is nasal breathing. To re-establish nasal breathing and prevent air from entering the oral cavity, an oral screen can be used to close the lips or oral cavity. This is particularly effective during sleeping hours. A thin rubber membrane cut or cast to fit over the labial and buccal surfaces of the teeth and gums is used. Initial designs may include windows to avoid completely blocking the airway passage. Construction of the oral screen. First, an impression of the vestibule is taken with the teeth in occlusion, extending to the posterior limits above and below the mucobuccal fold. Then, membrane formation. A 22-gauge rubber sheet is adapted over the plaster cast. It is removed and trimmed to size. Alternatively, a thin, even layer of wax of 24-gauge thickness is applied to the cast, followed by plaster to form a mold. Pure latex is poured into this mold and left to stand for 12 hours. Other methods include warming plexiglass to the molding stage and adapting it to the cast, and painting pure latex over the cast surface to an even thickness of 1/8 inch, curing it for 10 to 20 minutes at 130 to 140 degree Fahrenheit, and applying a second coat to achieve the final thickness. Specific uses based on malocclusion. It can be used in cases of class 1 skeletal and dental malocclusion. For children with class 1 skeletal and dental occlusion and anterior spacing, an oral shield appliance is used. For children aged 5 to 9 years with class 2 division 1 dentition without crowding, a monoblock activator aids in correcting the malocclusion and deterring mouth breathing habits. And interceptive methods such as chin cap are recommended for class 3 malocclusions. Ensuring a sufficient airway is essential before starting the treatment. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Stay tuned for more such videos.